Hello and welcome to this session of the Center for Podiatric Education. You are welcome to view any of the educational programs that are available at no charge on this site. If you are not familiar with the Center for Podiatric Education, this is a site that is maintained solely for the purpose of offering continuing medical education to healthcare providers at no charge. This particular session is offered to those who require certification for state relicensure in infection control requirement. Now, many states, such as New York, or in this instance, the state of Missouri, require certification on some regular basis in infection control, and this session is offering that information that is required. Now, you are more than welcome to view this presentation simply to improve your knowledge or to review your knowledge in the area of infection control. If you are going to be viewing this session to satisfy requirements for the state of Missouri and relicensure, this session will include 12 questions. Go ahead and complete the 12-question quiz. You will be given additional information regarding a submission of the quiz material to verify completion of this course. It is the law in the state of Missouri that podiatric physicians must complete during each educational cycle 2 hours of education in infection control. For those of you who are not familiar with the specific regulations, they specify that a podiatric physician has an obligation to guard as best they can against the transmission of contagious, infectious, and communicable diseases. This means, by, again, regulation definition, that a podiatric physician will be adequately trained in guarding against contagious disorders and communicable diseases, and at the present time the regulations require a minimum of 2 hours of continuing education in the area of infection control per educational cycle. Some of the things that you may not know and that you may want to assure that are completed in your offices: the regulations require that a podiatric physician have some type of written protocol within the office or available through the office regarding policies of that physician and office against the transmission of communicable diseases. The regulation also requires that every member of the staff be appropriately trained. And again, you can utilize this session. It's available to all healthcare providers and their staff at no charge in order to provide your staff members with adequate training. Non-medical staff is included in this regulation and should be trained to recognize and report to the podiatric physician instances in which there is the possibility of transmission of a contagious, infectious, or communicable disease. The regulation also requires you to maintain a record that would be available to those requesting this record, indicating appropriate training of each member of your staff, and that record should be maintained and available during the time that that individual is employed by the office and kept up to 3 years following the termination of that individual's employment. This includes an obligation of the podiatric physician not only to have knowledge but to utilize appropriate protocols to prevent the transmission of contagious, infectious, or communicable diseases in using equipment in your office, particularly equipment that may be semi-invasive or invasive. If you are maintaining an office, then obviously you will have, in all likelihood, some equipment that's used to provide sterilization. And the regulations require that you will test that equipment to make sure that it is properly functioning, that it is providing adequate sterilization in compliance with the recommendations of the manufacturer of the equipment that you are utilizing. If you determine to allow others to perform that supervision to assure that the sterilization equipment is properly functioning, then the regulations state that you have an obligation to assure that those who are carrying out this act for you have been doing so in an appropriate manner and consistent with the recommendations of the manufacturer of that equipment. You also may not know that the regulation requires you to maintain a contagion, infection, and communicable disease log so that any particular incidents of significance are documented with a summary of the facts involved in that, the date of the incident, any unique patient identifier, and a recording of the actions which you have taken to address the exposure that occurred, and also a summary of the outcome of that case. The regulations require that the log be reviewed monthly, and that a dating and timing of the review occur monthly with a signature in the log. The regulation requires that the log be maintained for a minimum of 3 years. This log should also include maintenance records of your sterilization equipment for at least 3 years, a copy of the protocols that have been utilized to assure maintenance of the sterilization equipment for those 3 years, and a detailed log indicating the training that the members of your staff have obtained, again, for maintaining that equipment. So that is a summary of the regulations in the state of Missouri that are listing the requirements for training and for maintaining a log and information regarding any communicable or infectious diseases. So let's talk now about sterilization and disinfection, and look at this subject. The objectives are to understand the state requirements in Missouri for infection control. We'll talk about disinfection and sterilization techniques. We will talk about time and temperature relationships with regard to disinfection and sterilization. I want to say a few words about the use of multi-dose vials, as this has become an area of increasing interest by regulatory agencies. We want to talk about the difference between sterilization and disinfection and sterilization techniques. I'd like to say a few words about the Center for Disease Control recommendations regarding sterilization and disinfection, and say a few words about handling certain blood-borne pathogens such as HIV and hepatitis B patients. So let's talk first about multi-dose vials. The use of multi-dose vials is commonplace in the offices of podiatric physicians. We use multi-dose vials for many purposes. I think it's fair to say most commonly for the use of local anesthetics, for the use of injectable corticosteroids, for the injection of active substances such as absolute alcohol in the treatment of nerve problems, perhaps injections of things such as vitamin B12, mixing agents with bacteriostatic saline. Frequently, we will utilize a syringe and needle and make multiple punctures in one vial just for obtaining one agent. And again, it's not uncommon in podiatric practices to mix multiple agents in one syringe. For example, a local anesthetic plus absolute alcohol, a local anesthetic plus a steroid, perhaps a local anesthetic and a steroid with vitamin B12. So this is not at all uncommon. The reason for the interest has been that since 2001, at least 50 outbreaks of transmission of infection from unsafe injection techniques have been reported to the Center for Disease Control. The majority of these have been bacterial infections, but many of them have also been viral infections that have been spread. The majority of these actually occur in outpatient settings. There have been reports of hundreds of patients who have become infected following improper injection technique with the use of multi-dose vials. It's interesting to note that this can also occur in the use of single-dose vials. Now, by definition, single-dose vials are to be utilized on one patient and one patient only. But about 1 in 20 healthcare providers actually admit that they utilize single-dose vials on more than one patient. And this type of practice can result in the transmission of some serious disease such as hepatitis C. Some brief history regarding this, looking at Mr. Peabody and Sherman, if you remember them from the old Bullwinkle and Rocky show. Just in 2008 alone, there was an incident in Nevada in which improper sterilization of an endoscopy center equipment potentially had exposed 40,000 people to hepatitis C. This also included actions by a provider who was reusing syringes and using a single-use medication vial on multiple patients. Similarly, there were 19 patients infected with hepatitis C in 2001 in a New York endoscopy center. So these things can occur, and unfortunately these events can be occurring due to unsafe practice. The Toronto Star had reported on the use of multi-dose vials and the use being responsible for an outbreak of hepatitis C in clinics in Toronto between 2011 and 2013, and there was examination of the use of multi-dose vials. So why worry? Well, perhaps Alfred E. Neumann is not all that worried, but I think you should be. We want to remember, and always want to remember, that our first responsibility as healthcare providers and as those who are working in the offices of healthcare providers is that of patient safety. That is always our first thought. And because of the issues with multi-dose vials, we have seen increasing initiation of hospital and healthcare institutional policies. And there's great concern about this. I recently served as an expert witness in a malpractice case in the defense of a doctor here in Missouri, and the patient had sustained an infection in a toe following a rather straightaway, simple correction of a hammer toe. Somehow, the plaintiff's attorney was able to locate a hospital policy that had been initiated absent the knowledge of the doctor. And the hospital policy forbade the mixing of agents from multi-dose vials in the operating room. Now, Everyone who is listening to this tape, I am certain, has had the experience as a student or a resident or in practice of going to the operating room and standing off to the side and mixing perhaps a short and long-acting local anesthetic, or perhaps even adding a steroid and then proceeding to injecting the patient. And yet it turned out that this hospital had a specific policy forbidding that activity because this was considered an area of public access and the possibility of contamination. The doctor was unaware of that policy. It's possible that your own hospital has a similar policy and you're not aware of it. Unfortunately, the patient did develop an arguable post-operative infection. The doctor was unaware of the policy. The plaintiff's attorney somehow was aware of the policy, and the case resulted in a settlement. So we have seen, at least here in Missouri, at least one example where the initiation of this policy regarding mixing of agents from multi-dose vials has resulted in a settlement in some litigation. So there are some medico-legal consequences, but more importantly is the patient themselves. Again, we want to follow appropriate protocols in order to protect our patients from injury and harm. Certain states, New York and Missouri being examples, require training in these areas to maintain licensure and accreditation. So multi-dose vials are familiar to all of us. They usually contain a liquid medication. Sometimes we have to reconstitute these, but they're intended for injection, intended for parenteral administration in some manner. And by definition, multi-dose vials have more than one dose of the medication. To be a multi-dose vial, they are labeled as such by the manufacturers, and they contain an antibiotic, or not an antibiotic rather, but an antimicrobial preservative. And the preservative, you must remember, is for bacteria. It does not have effects on viruses such as hepatitis B virus or hepatitis C virus or HIV virus. So we don't want to contaminate the multi-dose vials with viral organisms, because the preservative will not have an effect on these viruses. And if you utilize contaminated needles or utilize unsafe multi-dose access practices, the preservative is not going to protect the patient from injury. Now, it has been recommended that whenever possible, multi-dose vials should be treated similarly to single-dose vials, and that they should be dedicated to the use only on one patient. I don't believe this is likely practical, and I don't believe most listeners think this is practical, as most of us use multi-dose vials for use on different patients. The recommendations is that there should be a dedicated preparation area for the use of a multi-dose vial away from immediate patient treatment areas. So, for example, it's recommended that multi-dose vials not be kept in the operating room, in procedure rooms, on anesthesia carts, procedure carts, or in patient rooms or patient bays for fear of contamination due to the fact that various patients with various diseases go back and forth in these areas. If a multi-dose vial is placed in such an area, a patient treatment area, again, it's recommended that the multi-dose vial be used only for the one patient for whom we are intending use at that time, and that the multi-dose vial be then discarded. And the reason is, again, that we may have contaminated surfaces from prior patients that have been in that room. We certainly know that in using a multi-dose vial, we always want a clean needle We do not ever reuse needles. We do not ever use contaminated needles. If there's a break in technique, then the needle should be discarded. And if this occurs while drawing up the intended injected medication, then the entire syringe, contents, and needle should be discarded and a new needle utilized. If we reintroduce a needle that has been contaminated or reutilize a syringe that has been used on someone else, we run the risks of spreading either bacterial or viral infections. And again, remember that these viruses are not inhibited or killed by the preservatives in the multi-dose vials. So always follow safe injection technique. Some of the things that we never do: we never reuse syringes for more than one patient. We reuse syringes never. And we certainly don't want to reuse syringes to share accessed medications between patients. We do not ever use anything but aseptic technique. I think it's always good when doing any injection in the office, when dictating our note, to include in that note the fact that aseptic technique was utilized. And aseptic technique includes proper technique in drawing up the medication as well as administering the medication. So proper technique, always important. Now, when should you discard a multi-dose vial? Here again, there are policies in place for this. Anytime there's compromise of that multi-dose vial, or anytime you believe there is compromise of a multi-dose vial, perhaps you inadvertently touch the surface, the needle is now contaminated and has been introduced into that vial, you discard that vial. By a standard protocol, as defined by the Center for Disease Control, once you open any multi-dose vial, it is felt that it is acceptable to reuse that vial for 28 days, unless there is a specific recommendation otherwise by the manufacturer. And we do know that there are some agents, for example Botox, where there are alternate policies that are recommended. So once you puncture that vial, you want to label that vial as being discarded and put down a date, 28 days from the time of that initial puncture. Now, what about if a vial's been sitting on the shelf and it's been there more than 28 days but it's never been opened? If it's never been opened, then obviously you discard the vial as recommended by the manufacturer's expiration date. So each multi-dose vial will have available to you on the label an expiration date. And the expiration date is only applicable to unopened multi-dose vials. So here again, once that is punctured, the countdown of 28 days begins. Now, there is the question of, can I use this vial beyond the manufacturer's recommended expiration date? And this is the so-called beyond use date. And the general recommendation is that you not utilize the multi-dose vials beyond that date. So one can simply label the multi-dose vial, put the expiration date, 28 days following the first time it's opened, or you can use various stickers. There are stickers that are available. There are multi-dose vial calculators, expiration date calculators that are available. And if there is concern about contamination, and again, I don't believe this is standard of care. I don't believe that most podiatrists actually use these things, but you can actually purchase multi-dose vial adapters to, again, try to minimize the risk of contamination by using the adapters to withdraw the medication rather than introducing the needle directly into the multi-dose vial itself, so that one can apply these adapters and then withdraw the medication by putting the needle in the adapter rather than by puncturing the rubber top on the multi-dose vial itself. So again, when should multi-dose vials be discarded? And that would be 28 days following the initial needle puncture, or if never opened, they should be discarded at the manufacturer's recommended expiration date. For those of you who are viewing this tape for the purpose of relicensure requirements, here is your first question. I'd like you to mark this, true or false. Once used, a multi-dose vial should be discarded after 28 days. True or false? The answer, of course, is true, that multi-dose vials should be discarded after 28 days. What about single-dose vials? Single-dose vials, by definition, are approved for use on one patient only. Again, studies have indicated that about 1 in 20 physicians utilize single-dose vials for more than one patient, and this is considered inappropriate to utilize these on multiple patients. And the reason is that many of the single-dose vials lack antimicrobial preservatives, and so these are much more readily contaminated, and single-dose vials should be discarded after each individual use. Now, when we pick up our single or multi-dose vials, there's typically a rubber stopper, rubber septum on the top, and we should clean this off. And a number of agents are acceptable for disinfecting or cleaning the rubber top, the septum on the top, and this includes isopropyl alcohol. Various iodophores can be utilized, or approved antiseptic swabs. And again, this technique should be included in your office manual. Interestingly, there are contrary opinions regarding the use of single and multi-dose vials, and this is an example of such a contrary opinion. This is in, for example, the state of Oklahoma, and noting that these vials can be continually used, provided that they are properly maintained and properly stored. Let's move on to an important subject, and that is the subject of disinfection and sterilization in the podiatric office. Now, what is disinfection? Disinfection refers to the destruction of microorganisms, or the elimination of the products of microorganisms such as toxins, and this is by directly exposing the organisms or toxins to physical agents outside of the body or on the skin. Now, you want to keep in mind that some bacteria can go into a spore state. And when bacteria go into spore states, they can become more resistant to attack by disinfectants, so that some disinfectants may not be capable of killing bacteria in the spore state. They may not be sporicidal, and they may be sporostatic, meaning they don't allow the immediate growth of the bacterial spores, but they do not kill the spores. So disinfection refers to the destruction of the microorganisms or their toxins. There are certain definitions that you want to keep in mind. You want to look at your disinfectant and see what the recommended disinfection time is. and that is the time required for a disinfectant to achieve its maximal effect in killing bacteria or eliminating bacterial toxins. Now, this means that for many disinfectants, you may not simply be able to just wipe off the instrument, wipe off the skin, wipe off the surface of something in the office, and then immediately use that surface. There may be a waiting time, and frequently this is going to be information available to you on the bottle, on the container, or from the manufacturer. And again, it's good to have an office policy which identifies the disinfectant that's being used in the office and identifying a recommended time, so that if someone were to challenge your office policy, let's say a patient sues or is concerned that they had acquired some infection because of unclean practices in your office, it's nice to have an office policy that states this is the disinfectant that we use in this office, and this is the policy that we follow, including waiting for the recommended disinfection time before reusing equipment or before allowing another patient to have contact with that surface, and having the staff verify that yes, we did follow the appropriate disinfection time. The disinfection time, that is to say how long it takes before we've achieved maximum effect of that disinfectant, obviously is related in part to the strength of the disinfectant, the potency of the disinfectant, and what it is we're trying to actually disinfect. There's also the term terminal disinfection, and this refers to disinfection of a room in which there may have been contamination, a room in which we may have had a patient with HIV disease or a patient with hepatitis C or hepatitis B. And this is a situation where, because of the contamination, we're going to go ahead and disinfect that room and the contents of that room in order to prevent spread. So if there is some significant contamination or other event, it's nice to document that we have terminally disinfected that room. Here is your next question, true or false? The disinfection time refers to the time required for a disinfectant to provide its maximum effect. True or false? The answer, of course, is true. The disinfection time refers to the time required for the disinfectant to provide its maximum effect, and this is information that will be available to us on the container or through the manufacturer. And again, it's a good policy, reasonable policy to include in your office manual the agreed or accepted disinfectant and the disinfection time that is recommended. And obviously, we want to follow those recommendations between patients. There are some other definitions that we want to be familiar with. Sometimes we use the word aseptic, and this refers to an absence of pathologic organisms, and we oftentimes recommend that patients use antiseptics. The term antiseptic is a term that we utilize when we are trying to kill bacteria or other potentially pathologic agents from growing on living tissue. So that, for example, an antiseptic is something that is utilized in treating the skin, perhaps in cleaning the skin, preparing the skin for an injection or an incision or so forth. We also have the term cleaning, and we oftentimes state that instrumentation and surfaces, perhaps chairs, need to be cleaned. Cleaning is not disinfection. Cleaning refers to removal of foreign materials from whatever object is being cleaned, and it's important to note that cleaning should precede disinfection and sterilization. Now, if we have, for example, an instrument that has blood on it, we want to clean the instrument before proceeding or progressing to using a disinfectant, because disinfectants can be inhibited and may not be effective when we have placed that instrument in the disinfectant when there is, for example, dried pus or dried blood or some foreign material on that object. So maybe we're having a bad day and we're trimming a lesion, and the patient gets nicked, or perhaps we've performed an incision and drainage, and we now put that instrument in the disinfectant without first cleaning it. The foreign materials on that object may impair the ability of the disinfectant to work, and then when we go ahead and reuse that instrument, even though we feel that we've properly disinfected it or properly sterilized that instrument, we may in fact have harboring of viral or bacterial or other organisms underneath the areas of contamination. So typically we'll utilize soap and water. We will clean the instrument before disinfecting and sterilization is administered. In other words, we want to remove foreign materials to allow that disinfectant or sterilization technique to be effective. We sometimes use the word decontamination, and decontamination refers to any process, any procedure that reduces the infectious content, the microbial content, to allow safe handling and disposal of that material. So what about the word sterilization itself? What do we mean when we use the term sterilization? And sterilization refers to a process, any process, that eliminates and or kills all forms of life or biologic agents. So when we say we have sterilized something, we're saying that we have killed all transmissible agents on a surface or on an object that we're going to be utilizing for treatment of patients. Sterilization is different from disinfection. It's different from saying something has been sanitized or even pasteurized, in that the term sterilization means that we have killed, we have deactivated, and we have eliminated all forms of life and other biologic agents such as spores. If you are doing chemical sterilization, then you use the term chemosterilant. So by definition, sterilization means we have killed all biologic agents that could be responsible for the transmission of disease. Different organisms have different levels of resistance to sterilization. So that, for example, typical fungi and typical vegetative bacteria are most readily killed. On the other hand, certain forms of life, such as tuberculosis organisms, bacteria in spore form, prions, are most difficult to kill. Obviously, by definition, when we sterilize something, all of these forms must be killed. There are many ways to provide disinfection and many ways to perform sterilization. We can use physical agents and we can use chemical agents. Physical agents can include various forms of heat. This can include infrared light. It can include the old-time burners. We can utilize moist heat. We can utilize radiation, and we can utilize various forms of filtration. Very frequently in podiatry offices, we are using chemosterilants, and there are many different agents which can be utilized to provide chemical sterilization. One can also, although it's less commonly performed in the office setting, certainly utilize gas agents such as ethylene oxide. So there are both physical and chemical means for disinfecting and sterilizing. Certainly no one would be expected to memorize this chart, but it's just to remind those of you listening that as far as chemical agents go, there are many, many chemical agents that one can select to provide disinfection and provide sterilization. They all have their advantages and they all have their disadvantages. Many of these work by breaking down the proteins within the organism intended for destruction. Some of these work by disrupting the cell membranes themselves or various components of the cell membranes, but most commonly they work by denaturing the proteins. Some, such as phenolic compounds, work well as disinfectants but may have an odor that one finds irritating. Hydrogen peroxide is a commonly used antiseptic and disinfectant, as is benzoyl peroxide. And again, the key point is that one can choose any of these chemical agents, and so long as they are being properly utilized, they can be effective in achieving the destruction and elimination of bacterial agents. And this includes simple use of soap and detergents, which are surfactants, and these will disrupt bacterial membranes, viral membranes, and increase the penetration of various other agents which are disruptive to these living organisms. So again, the critical issue is to properly use these agents. There are also physical agents that can be utilized to disinfect and provide sterilization. Perhaps the classic example is boiling water to kill bacteria, that is to say moist heat. Probably for most of us, the autoclave is the physical agent most commonly utilized. The autoclave works by denaturing the proteins within the living organisms, and the typical setting for use of a protein, rather an autoclave, is 121 degrees centigrade at 15 degrees pounds per square inch, utilizing that autoclave for a total of 30 minutes. So utilizing an autoclave at 121 degrees centigrade for 30 minutes at 15 pounds per square inch is going to sterilize whatever's in that autoclave. It's going to kill everything. We hear the term pasteurization. This also serves to denature the proteins in potentially infecting organisms, but it's only applicable really to food products. One can utilize dry heat in the form of a flame. And again, there are other agents that can be used to physically kill bacteria, but are not typically utilized in podiatry offices. This would include ultraviolet light. It can include the use of X-rays. And again, those of you who are older will remember the days when we would walk in and out of operating rooms and down OR corridors, and we'd have these ultraviolet lights that were present that were being utilized to disrupt bacterial DNA and reduce the incidence of contamination. Cold in and of itself does not necessarily result in sterilization or disinfection. Cold is bacteriostatic. So when we, for example, put something in the freezer or refrigerator, this may inhibit the growth of bacteria, but it does not kill bacteria. So keep that in mind. Looking at some of the physical agents that can be utilized for sterilization or disinfection. Again, many may recall the widespread use of ultraviolet light in operating rooms and corridors. One of the problems with this is that there's not a total penetration of the UV light through the object. Generally, it's utilized to keep the air cleaner, reduce bacterial counts in certain areas to reduce contamination. One can also utilize gamma radiation, that is to say ionizing radiation, which obviously is going to be stronger than ultraviolet light. In case you're interested, ultraviolet light works by breaking up the bonds, the connections, if you will, in the DNA. So it creates defects in bacterial DNA, defects in viral DNA between the thymine and adenine and cytosine and so forth, and does not allow replication of the bacteria or virus. Radiation similarly affects the DNA composition of the organisms and destroys the microorganisms as well as spores. If you utilize radiation for sterilization, which I think is highly unlikely, but if you do, and your name is not Ulrika Goldfinger, then you want to remember the items are not left radioactive. So this is not an issue with radiation sterilization. This is sometimes utilized by industry for repackaged organisms. What about filtration? With the process of filtration, we are using some kind of membrane to run our material through. Obviously, this is going to be having some association with size limitations. So filtration will remove most bacteria, but small bacteria and viruses and mycoplasma organisms will get through the sterilization filtration system because they are smaller than the filter itself. So when something says it has been treated by filtration, keep in mind this does not technically mean that it is sterilized. And this is important in case someone, some rep or company is trying to have us utilize some products that they're telling us to employ in patient care. And if this is something to be placed in the patient, for example, and it has been filtered, remember that does not mean that it is sterilized. And typically filtration is utilized for certain substances that will be destroyed by, for example, heat or radiation or other forms of sterilization. So keep in mind that filtration is not sterilization. So here is your next question. True or false? Filtration does not kill all bacteria. The answer, of course, is true. That when we are given a product to utilize on a patient and we are told that it has been, quote, sterilized, close quote, or treated by filtration, remember that that does not mean there are not bacteria present. Probably heat sterilization is the most important and most common means by which the average podiatric office will disinfect and sterilize their instrumentation. And those of you, again, who are old may remember the old Bunsen burner when you were working in microbiology lab and you'd have your little loops and you're going to be transferring agents and you wanted to make sure you destroyed bacteria from the prior experiment. You would place your little loops in the Bunsen burner. I don't think we see many of these around podiatry offices any longer. And this was utilized for loops and knives and so forth. And there were also hot air ovens that were available. It's a long and interesting history regarding the use of heat. And one of the early recommended techniques was tindalization. And this was a technique that recognized the fact that when you, for example, use moist heat, let's say you boil water, you will kill the living bacteria, but you won't kill the spores. And tindalization was a technique to reduce the effects of sporulating bacteria. So what you would do would be to boil water for 20 minutes. This would kill all the living bacteria that were in the water at the time you boiled it. You would then allow the water to cool and incubate it for 24 hours. Now what would happen would be the organisms that were in spore form would then start to grow. You would then reboil the water again for 20 minutes, and that would kill the sporulating rejuvenated organisms. You would then allow that to cool, incubate for 24 hours, and then reboil a third time. So tyndallization was an effort to not only destroy all bacteria in, for example, a given liquid, but to also then account for spore-forming bacteria. Certainly, Louis Pasteur was is a name that is well known to any healthcare provider, and we hear the term pasteurization. Most typically, we associate this with dairy products, with milk products, and you want to remember that pasteurization is not sterilization. It is a process by which we reduce the number of living bacteria, but we don't eliminate all bacteria. So pasteurization is a process that has several temperature variations. One can utilize a temperature of 62 degrees centigrade for a half hour, 30 minutes. You can utilize a temperature of 71.7 degrees centigrade for 15 to 20 seconds, or a temperature of 138 degrees centigrade for less than 1 second. But keep in mind that a pasteurized product is not a sterilized product. It simply means that the number of bacteria that are present have been reduced sufficiently to assume that the product is not going to be harmful. This is probably the most common means by which the average podiatry office provides disinfection and sterilization, and that is by the use of an autoclave. And in an autoclave, we place our object to be sterilized in the autoclave. We then lock down and seal the autoclave. The air is replaced by saturated steam. The steam under pressure comes in contact with the instrumentation or objects that we wish to sterilize. They are then again typically subjected to a temperature of 121 degrees centigrade at 15 pounds per square inch, and a time of between 15 and 30 minutes, typically 30 minutes, is utilized. If you use a higher temperature, you can decrease the time of sterilization. So here is our next question: true or false? When properly performed, an autoclave kills all bacteria. The answer, of course, is true, that when utilized at a proper pressure, for a proper time, at a proper temperature, an autoclave will kill all bacteria and provide sterilization. What do we look for in terms of time for sterilization? This depends on what we're putting in the autoclave. If we're using instrumentation or other agents that are wrapped up, perhaps packs of instrumentation for some procedures such as surgery, then again the correct temperature is 121 degrees centigrade for 30 minutes at 15 pounds per square inch. If we have unwrapped instrumentation, we can use a temperature of 132 degrees centigrade for at least 10 minutes at 27 pounds per square inch. If we are placing unwrapped metal instruments in the autoclave, then we can utilize a temperature of 132 degrees at 27 pounds per square inch for 3 minutes. Again, I think most typically we place surgical packs, procedure packs, wrapped instruments in the autoclave, and the correct time would be 30 minutes. the correct temperature, 121 degrees centigrade, and the correct pressure, 15 pounds per square inch. So this is our next question, true or false? For wrapped instruments, the proper autoclave settings are 121 degrees centigrade for 30 minutes at 15 pounds per square inch. And the answer is, of course, true, that if we're going to autoclave wrapped instruments, we want to maintain the autoclave at 121 degrees centigrade for 30 minutes at 15 pounds per square inch. So the advantages of the autoclaves typically utilized in the office, that this kills bacteria, fungi, and spores. It tends to be the least expensive and safest way to provide sterilization. It is relatively quick, it is non-toxic, and it is really not very difficult to obtain and utilize autoclaves. The disadvantage, the big one, is that you cannot use it for certain organisms that are certain products that may be heat or moisture sensitive, and there is room for human error. Autoclaves will not work unless they are properly used. And again, this is why it is important to follow your autoclave manufacturer's recommendations. But again, typically appropriate time, appropriate pressure, and appropriate temperature will give you adequate sterilization. We hear the term flash sterilization, and this is a process that refers to use of an autoclave to sterilize an unwrapped item that may have been dropped right before you intend to use it, or maybe dropped during a procedure, so that we're doing a procedure and a critical instrument falls, hits the floor, or otherwise becomes contaminated, and we need it immediately. So flash sterilization is utilized when there's an unanticipated need for an instrument that becomes contaminated, and we have to quickly re-sterilize that instrument. And if there are no other alternatives in terms of alternative instrumentation available, then flash sterilization becomes an acceptable means to deal with the problem. One of the issues with flash sterilization is it is not as effective as traditional sterilization with an autoclave, and sometimes we use this too much. So, for example, we may have more procedures scheduled than we do have available to us instrumentation. So the operating room staff or surgery center staff may say, okay, doctor, we just got done using the equipment on someone else, and we'll go ahead and flash sterilize the equipment so it's available for you, and is that okay with you? It should not be utilized as a first choice elective technique in deference to having adequate supply of instrumentation. And a common example is a case we have scheduled, and the rep from the orthopedic company shows up right before the case and says, "Gee, doc, sorry I'm late, but don't worry, we'll go ahead and flash sterilize the instrumentation." The guidelines for a flash sterilization are listed here, and for some power equipment, the time depends on the nature of the equipment and the composition of that equipment. So there are guidelines for flash sterilization that can vary depending on the instrumentation or object that you're having flash sterilized. Generally, if it's a metal object which is non-porous and does not have a lumen, it's not hollow, then flash sterilization can typically be performed at 270 degrees Fahrenheit or 132 degrees centigrade for 3 minutes. But keep in mind, this is for non-porous objects, so that, for example, cannulated screw systems, cannulated drills, and so forth have to be flash sterilized a bit longer. So if they have a lumen, if they're porous, then 132 degrees centigrade between 4 and 10 minutes is necessary, depending on how the flash sterilization is to be performed. Now, the Center for Disease Control does have a policy regarding flash sterilization, and you want to keep in mind that it is considered acceptable if the instrumentation is clean. And one of the problems you may have is if sets of instruments are being, quote, flash sterilized between cases, so that some other surgeon has just finished using that instrumentation. Sometimes the instrumentation may not be properly cleaned, and as a result the flash sterilization may not be effective, because when instrumentation is not cleaned, flash sterilization or any sterilization or disinfection may not work. So it's acceptable if there's insufficient time to sterilize by autoclave instrumentation or other objects by preferred method. Also keep in mind that because flash sterilization is not as effective as standard autoclave sterilization, there is the potential to transmit serious infections, so that flash sterilization is not recommended for implantable devices, particularly devices implanted into a body cavity. So while it's recognized that the use of flash sterilization may be unavoidable in some circumstances, a critical object that you require simply becomes contaminated, it's important that you understand this is not preferred. And this is the reason that operating rooms and facilities have you sign a release agreeing to flash sterilization, so that you are accepting some degree of liability when you agree to allow flash sterilization, because you are increasing the risk to a patient. And here again, we have had lawsuits here in Missouri. Some of them have been rather significant, where patients have developed rather serious post-operative infections that resulted in some significant damage, and somehow the plaintiff attorneys were able to find out that the instrumentation was flash sterilized. So if you have to do it, you have to do it, but keep in mind that flash sterilization is not a preferred means to sterilize anything. The effectiveness of autoclaves and the use of autoclaves depends on many things. How you wrap the instrumentation is of course important, and the autoclaves must be properly functioning. Again, it is critical that these objects be cleaned before being placed in the autoclave, and things that have hinges and little screws and have multiple components, these things must be properly scrubbed and cleaned before placing them in the autoclave. There are, of course, different types of autoclaves that are available. The critical issue, again, is proper use, proper maintenance of the autoclave, and making sure the instruments have been cleaned before proceeding with autoclave use. The regulations for a podiatrist in the state of Missouri include that there is proper monitoring of the function of the autoclaves to assure that the autoclave is in fact performing the job for which it has been intended. There are 3 basic methods for monitoring autoclaves. You can use physical methods such as a thermocouple to measure the temperature that has been achieved. There are chemical strips and chemical indicators that you can use, again, that will change color when the strip or monitoring device has been exposed to proper temperature for a proper time. And there are biologic monitors, which are the best, and these are various forms of spore-bearing organisms that are placed in the autoclave by various means and tested to show that these spore-forming organisms have been killed. You want to remember that spore-forming organisms are one of the most resistant forms of organisms, so that it is assumed that if we are able to successfully kill those organisms, that we have succeeded in properly autoclaving and sterilizing those instrumentation. So we have various mechanical monitors, and this will confirm the time that the autoclave was functioning at 121 degrees. It will confirm the appropriate temperature and confirm the appropriate pressures. And the autoclaves will have various recording devices and gauges and provide a printout. And again, you want to make sure that if this is the method by which you are monitoring your autoclave, that these are recorded, these are preserved, and that we are assuring that not only is this information available, but we are using that information to confirm that indeed the autoclave is working properly. So here again, you may want to consider placing that in your manual, that the individual doing the autoclaving is responsible for evaluating the information that's available from the mechanical monitors and confirming that an appropriate time, temperature, and pressure was achieved. The chemical monitors are commonly utilized by many podiatric physicians. These are usually strips or tapes that will change color. They have some type of thermochromic ink, and what it does is it tells you that the proper process has been performed. It does not guarantee the sterility of the contents. It merely states that yes, appropriate environmental conditions have been met to state that the autoclave was functioning at an appropriate temperature for an appropriate time. Probably the best monitors are biologic monitors, and these again are non-disease causing spore-forming bacteria. There are several genus and species that are utilized, and these indicate that indeed the autoclave has successfully killed the spore-forming organisms, which means that it's likely that everything in the autoclave that was biologic was killed. This is a form of testing the autoclave when biologic monitoring is done. It should be typically done on a monthly basis. Now, once you've autoclaved an object and you put it in the closet or in the drawer, the question is, how long is it sterile? And this is a difficult question to answer, but most often the standard following use of instrumentation or other objects following the use of an autoclave is event-related sterility. That is to say that it's assumed that the contents are now sterile and will remain sterile unless there's some violation of the wrapping or some other event has occurred that, in your opinion, could have affected the sterilization of the contents. So at one time, it was various arbitrary expiration dates were given, so you'd sterilize something and say, okay, this will be considered disinfected and sterilized until such and such a date. But now it's generally considered that if there's no event that occurs that you think will compromise the sterilization, that is to say there's no tear or unwrapping or soaking of the contents, this type of thing, the seal is not broken, it's generally assumed that the contents remain sterile. So once autoclaved within reason, the contents are considered sterile unless there's been some event that compromises the contents of the instrumentation. So how long is enough to consider the contents as remaining sterile. Again, it's event related. So you want to look at the quality of the wrapping material, the conditions under which the materials have been stored, and any potential violation. And here again, you probably want to define some type of policy for your office and instruct the employees to, of course, follow those policies. So if they're transporting something and there is a violation of the wrapping, or something's found to be particularly wet, and you think there's any possibility that there has been some perforation or exposure to the environment, then of course you want to re-autoclave. So here's our next question: true or false? Each facility and or provider will have a unique policy and procedure regarding shelf life. And the answer, of course, is true. You will define your personal office policy for how long something is considered to be sterile following initial autoclaving. We want to continue with a discussion of chemical sterilization. So while it's true that most individuals typically utilize an autoclave for operative packs and so forth, many podiatric physicians will utilize chemical sterilization. We tend to utilize chemical sterilization for our day-to-day instrumentation and for use of sterilization when we have materials and products such as plastic devices or endoscopic instrumentation that would be harmed by the sterilization process in an autoclave. Most commonly, ethylene oxide is utilized in institutions, which inactivates the DNA in microorganisms. Of course, ethylene oxide has to be properly utilized and mixed with an inert gas in order to prevent explosions. There are requirements for the use of ethylene oxide for sterilization, and again, this is something that's typically utilized in the institutional setting. The use of ethylene oxide chambers for sterilization requires high humidity. Typically, the humidity is maintained somewhere between 50 and 60% at a temperature between 50 and 60 degrees centigrade. It is a longer process, and the exposure time is a minimum of 4 hours, typically 6 hours. The other chemical agent that's utilized quite a bit for sterilization is activated alkaline buffered glutaraldehyde. This typically requires 20 minutes of disinfection. For killing of spores, however, glutaraldehyde requires between 2 and 3 hours. Ethylene oxide, again, is typically utilized for many of our scopes. It is very toxic, and it is a known carcinogen. It is flammable when not mixed with an inert gas or mixed with Freon. Generally, the instrumentation must be cleaned and dried prior to the use of the ethylene oxide. Ethylene oxide is, again, typically not used in the office setting. It is quite expensive, and besides the 4 to 6 hours of sterilization, we have an aeration process. So ethylene oxide sterilization is just not practical. It is expensive, it is toxic, it is carcinogenic, and it takes a great deal of time to carry out. And again, aeration is required in order to remove carcinogenic, toxic residues. This is a typical ethylene oxide chamber, and there has to be an exhaust system outside the office, outside the hospital, to remove the ethylene oxide neon or ethylene oxide freon exposure. Monitoring is done with bacterial spore testing on every cycle. So here's our next question: true or false? Ethylene oxide is highly toxic to body tissues and is a known carcinogen? The correct answer is true. Ethylene oxide is highly toxic to body tissues and is a known carcinogen. I'd like to move on to disinfection, which is commonly performed in the office setting on a daily basis. And again, if you recall, the definition of disinfection is the destruction of pathogenic microorganisms or the inactivation of their toxins by the use of a chemical or physical agent. And this is something that's applied to the surface. And again, you want to remember, as we mentioned earlier, that not all disinfectants will kill spore-forming bacteria. So they may not be sporicidal. They may just inhibit the growth of the bacteria in spore form, but not kill them. Again, you want to remember your basic definitions. You want to look at the bottle or container to see the disinfection time. What is the time that the disinfectant must be applied in order to achieve its maximum effect, and have an office policy that indicates that when a particular disinfectant is utilized, those utilizing it will allow it to remain in place for the recommended disinfection time before moving on to reutilize that instrumentation or surface. And again, this will depend on the potency of the disinfectant and what it is that you're trying to disinfect. And again, the term terminal disinfection, meaning a room that has become contaminated, perhaps a chair that's become contaminated, and we're going to terminally disinfect, that is, remove bacteria from that surface. Now, there are defined levels of disinfection, and certainly, for example, we don't require terminal disinfection after every patient that we see. So the question is, what is it that we are disinfecting for? So there are low, intermediate, and high levels of disinfection. Lower levels of disinfection will remove most bacteria. It will destroy some fungi and will be effective for some viral organisms. Intermediate levels of disinfection will remove some spore-forming bacteria. It will kill most vegetative bacteria, tuberculosis organisms, fungal organisms, and enveloped viruses such as HIV virus or hepatitis B. High levels of disinfection are required when we are concerned about spore-forming bacteria, and we want to make sure that we kill the spore-forming bacteria. And again, high levels of disinfection will kill viral organisms, both enveloped and non-enveloped, fungal organisms, and tuberculosis. So disinfection and techniques for disinfection and selection of disinfectants are going to be somewhat dependent on what level of disinfection we require. Typically, for non-contaminated exposures, patient to patient in the office, low or intermediate levels of disinfection are probably satisfactory. So some people have referred to levels of disinfection in other ways. For example, there can be non-critical, semi-critical, and critical. So a non-critical, that is to say lower levels of disinfection, would involve objects that come in contact with intact skin. For example, your Doppler, or blood pressure cuffs, or the chair on which the patient is sitting. So these are instruments that come in contact with the patient's skin from patient to patient, but they do not violate the skin. They do not violate the internal contents of the patient. And for those patients, only low or intermediate levels of disinfection are required. There are semi-critical levels of disinfection, that is to say intermediate disinfection, that may be required. This would be something, for example, like a thermometer that's placed in the patient's ear, or mouth, or objects that come in contact with non-intact skin, for example, treating a diabetic ulcer. And then there are high levels of disinfection, critical disinfection, and obviously these would be instruments that are involved in surgical procedures or violation of intact skin. Looking back at various techniques for disinfection, whether they are low, intermediate, or high, one can use physical agents or chemical agents, and one determines the appropriate level of disinfection, the appropriate agents to be utilized, and again, these had to be utilized in an appropriate manner. We spoke earlier about the variety of chemical antimicrobial agents that are available to you. The majority of these, again, working by disruption or denaturation of bacterial and viral proteins. And when properly used, many of these, such as glutaraldehyde, are more than adequate to achieve high levels of disinfection. Now, some questions that are commonly asked: what about resistant bacteria? What about the patient that comes to our office and has, for example, a history of multi-drug resistant bacteria? The patient that comes to our office and has a history of MRSA, for example. And the question is, are the standard disinfectants satisfactory for these patients? And the answer is yes. What's important is the concentration of the disinfectant. And there is not a direct correlation between bacterial resistance, for example, MRSA resistant Staphylococcus, and the inability of a disinfectant to kill that germ, because most of the disinfectants that we use day to day in our offices are in concentrations that exceed the bactericidal level. And there's no data that is available that would suggest that if a bacteria is, for example, MRSA or multi-drug resistant, say gram-negative, that it is somehow going to be more resistant to disinfection with germicides, so that the same high level of germicide can be utilized for these patients. So it's important to consider cleaning and disinfection in dealing with patients who have resistant organisms such as MRSA or vancomycin resistant enterococci organisms. These are very, very important issues. We certainly want to disinfect these rooms, but here again, we know that the typical disinfectants that we are utilizing in the office have concentrations that far exceed the inhibitory concentrations and cidal concentrations for these, and we don't really have good data to suggest that, for example, methicillin-resistant staph is going to be more resistant to proper disinfection techniques. So because the concentration of the disinfectants that we utilize are much higher than the inhibitory or cidal concentrations, even for very resistant bacteria, standard but properly performed disinfection is going to provide adequate disinfection and cleaning, and reduce the likelihood of bacterial transmission from patient to patient. Can disinfectants induce resistance? It has been suggested in some studies that repeated exposure to the same disinfectant can be technically or theoretically associated with the development of resistance. The fact is, however, the studies have shown that this development is not clinically significant, is unlikely to compromise the effectiveness of the disinfectant. So, in theory, one might consider rotating disinfectants to avoid the development of resistance. That certainly would, from a theoretical standpoint, seem to make sense, but realistically, we have no evidence to suggest that the development of resistance to a disinfectant by repeatedly using the same disinfectant in your office is of any true clinical significance, and that you're not going to have an office that now has, for example, a glutaraldehyde resistant bacteria. The things that influence the effectiveness of disinfection in your office would be the temperature at which it's utilized, whether or not you're utilizing that disinfectant at the proper concentration. And you want to make sure that, again, disinfectants are being mixed and utilized at a proper concentration. We talked about disinfection time, and again, this is critical. You look at the disinfection time for the particular product that you are using, and you follow that recommendation and not reuse the objects or surfaces or instrumentation until that disinfection time has been achieved. You want to remember that not all disinfectants are equally effective. For example, chlorhexidine is typically utilized by many individuals, and this has greater activity, for example, against gram-positive organisms than against gram-negative organisms. You want to make sure, as we mentioned earlier, that the instrumentations and surfaces are properly cleaned before being disinfected, so that dirt, organic material, dried blood, pus, mucus, and so forth are removed before utilizing the disinfectant. And if not, we will have less effectiveness of that disinfectant, and it may not result in appropriate sterilization as we require. Next question, true or false? Disinfectants may be inactivated by blood and pus, which is not cleaned off prior to disinfection. The answer is, of course, true. Disinfectants can be inactivated by the presence of foreign materials, and instruments must be properly cleaned before proceeding with disinfection. We want to look at potential resistance to the killing of bacteria by our disinfectants. And as a general rule, gram-negative organisms are a bit more resistant than are gram-positive organisms to disinfectants and antiseptics. However, once again, it's important to realize that disinfectants are made in concentrations that do exceed the inhibitory and cidal concentrations necessary to kill bacteria. Non-enveloped viruses are a bit more resistant than enveloped viruses such as HIV or hepatitis B. So here again, we want to use stronger disinfectants if we're concerned about viral exposures. We want to remember that mycobacteria, which we can see particularly in immunocompromised patients such as AIDS patients, are going to be, again, more resistant to disinfectants and antiseptics and require stronger disinfectants and require stronger antisepsis. We want to remember that the colder the temperature, the more disinfectant activity is inhibited. Probably the most important issue is cleaning the instrumentations of organic matter, because organic matter will interfere with the effectiveness of a disinfectant in several manners. You may have actual biochemical or physical interaction between the disinfectant and the organic matter, so that by the time the disinfectant reaches the surface of the object to be disinfected, it is no longer going to be effective. And you also have just the physical blocking, the lack of access of the disinfectant to the surface of the material because of dried pus or dried blood or whatever. And lastly, you want to remember that the longer the disinfectant is applied, the longer that and making sure that we follow the disinfection time recommended by the manufacturer, the more effective the disinfection will be. looking at some of the more common disinfectants that are available. Phenol compounds and phenolic compounds are seldom utilized. They do have the potential to injure patient tissues. They do inactivate enzymes. They are more effective in the presence of uncleaned organic matter. Hexachlorophene can be utilized as a disinfectant, particularly for gram-positive organisms, a little bit less effective for gram-negative organisms. Hydrogen peroxide is something that is frequently utilized in offices for disinfection. It gives us a high to intermediate level of disinfection when utilized. Some examples of phenolic compounds would be things such as Lysol or Dettol, and these provide an intermediate level of disinfection. Biguanides are commonly utilized. Things such as chlorhexidine, iodine-containing compounds are frequently utilized in offices such as betadine. These are iodine in the old days. These are effective for reduction of bacterial count, endospores, fungi, and killing some viruses, and chlorine-containing compounds typically utilized in wound cleaners, for example. Chlorine-containing compounds, most common example would be bleach, again in weakened form, the sodium hypochlorite utilized in many wound cleaners, and this is very effective in killing bacteria, including anthrax. We frequently wipe off tops and injectable membranes with alcohol. Alcohol concentrations between 60 and 95% are effective. Typically, alcohol requires 5 minutes to kill all bacteria. It provides an intermediate level of disinfection. Alcohol is bactericidal as well as fungicidal. It will not kill non-enveloped viruses and does not work on endospores. Question, true or false? Alcohol kills bacteria and fungus organisms. And the answer is true. In appropriate concentration between 60 and 95%, alcohol will kill both bacterial and fungal organisms. Heavy metals are frequently utilized as a disinfectant. Some of the more common examples are silver nitrate, silvadine, silver sulfadiazine, copper sulfate, zinc chloride, used, for example, typically in mouthwashes that we see in the pharmacy. So heavy metals can certainly be used as antiseptics and disinfectants. Peracetic acid is commonly utilized for sterilization and disinfection of instrumentation that cannot be placed in an autoclave, plastic devices, endoscopes, and so forth. Again, if we're using peracetic acid for sterilization, it is important that whoever is responsible properly disassembles and cleans the instrumentation so that organic material, dried blood, and so forth is completely removed. It takes 30 minutes to have peracetic acid effectively sterilized, so make sure if you're using Stirus that it's utilized for 30 minutes, and then the instrumentations should be removed and immediately utilized. Glutaraldehyde is something that is very commonly utilized for disinfection. It is typically utilized in a 2% concentration. Probably the most common form of glutaraldehyde is Sidex. This provides a very high level of disinfection, and it's used for instrumentation that cannot be utilized in heat. A little less commonly utilized these days, but again, not infrequently utilized, are quaternary ammonium compounds. Savlon and others are examples of these that are available as sprays. These are adequate where there's no invasion of the patient's skin, where we're going to have just the contact of intact skin of the patient with the surface, for example, a podiatry chair. These could be utilized on the walls and floors. Again, it's important to remember that because they are not particularly strong, quaternary ammonium compounds are not going to be very effective if there's organic matter. It does not seem to be very effective against gram-negative organisms. If a patient is in the office and there's a consideration of contamination with hepatitis V or HIV, then the recommendations of OSHA are that an agent that is effective against tuberculosis organisms be utilized. We want to make sure that we have an intermediate to high level of disinfection following exposure of our materials to hepatitis V or HIV. One component of disinfection following exposure to HIV or hepatitis B contaminated blood is that all working surfaces be cleaned and decontaminated with an appropriate disinfection after contact. So again, this is a requirement of OSHA. So if you are treating patients that are known to be HIV or HIV infected, then appropriate disinfection of the surfaces, for example, wiping down of the chair, equipment with which the patient has come in contact is required. So you want at least an intermediate or high level of disinfection, and this should be included in the office manual as one of the standard office protocols. Now, is routine surface disinfection necessary? And the answer is not always. Surfaces that are considered non-critical because they contact intact skin do not have to be disinfected between patients. For example, the patient sitting in the podiatry chair, they're wearing clothes. If there's no exposure of their skin to the chair surfaces, for example, you don't have to routinely wipe down the floors or wipe down the chairs or walls between patients. Now, what about other areas that can be contaminated? For example, we have patients standing on devices while taking x-rays. You may be using blood pressure cuffs for taking ankle pressures or blood pressures, stethoscopes, instrumentations utilized perhaps to measure skin temperature. These can become contaminated. These are considered non-critical so long as they are not being placed on open or exposed skin, and that being the case where there's no break in skin continuity, where we have a non-critical medical surface being used, low to intermediate disinfection is generally recommended. So examples again might be Dopplers. They might be the scissors that you're utilizing to cut bandages off between patients. It may be the podiatry chair, maybe doing diagnostic ultrasonography, x-ray stands, and so forth. So low to intermediate disinfectants are generally recommended. And of course the big one is that of wearing gloves and hand washing between patients. When looking at the use of disinfectants, you also want to remember that germs can lie in hinges between component instrumentation, so that it's a lot easier to clean and disinfect, say, the surface of a counter than it is, for example, the hinge between the hemostat parts, or the hinge of a scissor, for example. So you want to remember that unless the germicide, the disinfectant, can get to different crevices, you do not have proper disinfection. The other variable that we consider when selecting disinfectants is the concentration of the disinfectant. And we know that the more concentrated the disinfectant, the greater the efficacy. That's common sense. The more concentrated the disinfectant, the shorter the disinfection time is going to be. So we want to make sure that, again, where there's any question at all regarding contamination, we want to use strong, concentrated disinfectants in treating our patients. True or false? The more concentrated the disinfectant, the shorter the disinfection time. The answer is, of course, true. The more concentrated the disinfectant, the shorter the disinfection time will be. So in looking at disinfection time, we want to look at the labeling on the container, and typically the contact time, the disinfection time, will be specifically noted, and this will include labeling for use of the disinfectants for contamination with hepatitis B, patients who are HIV positive, patients who have a history of tuberculosis exposure. And most commonly, the recommended contact time will be 10 minutes for the disinfectant in HIV patients, hepatitis V patients, or patients that have been exposed to tuberculosis. However, studies have demonstrated that there is significant reduction in contamination with contact time as little as 30 to 60 seconds. So that use of very concentrated disinfectants will reduce, again, that disinfection time. You want to look carefully at the labeling. Some of the disinfectants may have a contact time between 1 and 3 minutes, and by law, you are required as a healthcare provider to follow the recommendations for the disinfectant as noted by the manufacturers and placed on the label. So as part of your office manual policy, again, it should be clear that whatever disinfectant is selected, that those utilizing that disinfectant will be following the recommendations of the manufacturer. Low-level or weaker disinfectants are satisfactory, again, for non-critical surfaces and where the patient has intact skin, and higher, stronger disinfectants, again, for contamination with non-enveloped viruses and for tuberculosis. Cleaning of the instrumentations, again, prior to disinfection is most important. So if you're using scissors and hemostats, things with hinges, they should be opened up and scrubbed before a disinfection. In general, the greater the degree of contamination or exposure to bacteria, the more time disinfectants require to destroy the organisms, so that it is important to allow access of this. And so remember to instruct those responsible for cleaning that proper cleaning of the hinges is going to be important. As we mentioned earlier, if there's organic matter remaining on the instrumentation, this can affect the ability of the disinfectant to work in two ways. Number one, you will actually have physical interaction between the disinfectant and the organic matter, and this will reduce the concentration and effectiveness of the disinfectant. And number two, it may actually make a true physical barrier so that the disinfectant cannot access the surface. So open up hinges, make sure that instrumentation is cleaned and scrubbed prior to disinfection. Next question, true or false? blood and pus should be cleaned off instruments prior to disinfection. The answer is, of course, true, that instrumentation should be cleaned and blood and pus removed prior to disinfection. So here we are with looking at our Mayo stand following a procedure, and we have our needle driver and scissor covered in blood, and all of this has to be properly cleaned and scrubbed, the instruments opened, the hinges cleaned before disinfecting. Disinfection also requires cleaning so that we can remove biofilms. We want to remember that bacteria will grow on these surfaces even if we can't see obvious organic material. Many bacteria will produce a complex polyglycocalyx or slime layer, and these biofilms will grow over the bacteria, and oftentimes biofilm producing bacteria tend to be more virulent, and biofilms are important because they will block the penetration of the disinfectant so that it can't get to the bacteria, making the disinfectants less effective. So here again, reduction of biofilms on the surface of our instrumentation and other objects in the office is important, and this is best removed by scrubbing and then following with the use of an appropriate germicide. So thorough cleaning is critical before placing our instruments into some liquid for disinfection or placing them in the autoclave for sterilization, because we will have biofilm formation and we will have decreased effectiveness of our germicides. What about cleaning between cases? All operating rooms should be cleaned between cases. All linen and waste should be removed in appropriate bags between cases. The bed should be wiped down, furniture wiped down. Anything that comes in contact with the patient needs to be cleaned and wiped down, and a disinfectant floor mop utilized between cases. It is recommended that on a weekly and monthly basis for operating room areas where procedures are done, that the walls and ceilings be wiped down, as well as the lights and monitors with disinfectants. Air vents and grills can serve as reservoir for bacteria and should be cleaned and wiped down. Storage cabinets and supply areas should be cleaned and dust removed. Terminal cleaning is typically performed following the last case of the day. Procedure rooms should undergo terminal cleaning once a week, or following any dirty case where there's been exposure to, for example, vancomycin-resistant enterococci, vancomycin-resistant staph, or methicillin, oxacillin-resistant staph, or exposure to any significant pathogens such as tuberculosis. True or false? Terminal cleaning should be performed following cases contaminated with methicillin-resistant Staphylococcus aureus. And the answer is, of course, true. Terminal cleaning should be performed following cases contaminated with MRSA. Endoscopes can generally not be autoclaved. This requires disassembly. This requires appropriate scrubbing and cleaning, and then it requires appropriate sterilization. Typically, glutaraldehyde at a concentration of 2% is utilized for 20 minutes in order to prevent the transmission of disease. Endoscopes should be exposed to high-level disinfection to cover for tuberculosis, hepatitis B, hepatitis C, and HIV. Again, the specific policies for cleaning of endoscopes should be memorialized in your manual if you're doing these procedures in the office setting and are responsible. It is generally assumed that patients may be contaminated with bloodborne pathogens, and therefore we want to go ahead and utilize a high level of disinfection on these patients. So we have completed the review of management of contamination and infection and potential transmission of disease, infectious disease. Hopefully this has been of some value to you, and this is available again to any healthcare provider and office staff in an effort to satisfy the requirements for the state of Missouri. Thank you for your attention and have a good day. You are certainly invited to view other educational offerings here at the Center for Podiatric Education. Just click on the educational resources, video lectures, and enjoy the education available. Thank you.